Good morning. Thanks everyone for being here. Thanks Dr. Christensen for inviting me this year. When Jared asked me to give some talks, he said that there were some requests for some plain film sort of focused talks, so these will be that. So my outline this morning is I'm going to talk very briefly about radiographic findings that are used for risk assessment by our clinical colleagues. Then I'm actually going to spend most of the time talking about clues to suggest that you're not dealing with an ordinary run-of-the-mill community-acquired pneumonia. I think most of us feel pretty comfortable looking at radiographs and saying, yeah, that looks like a pneumonia or whatnot, but I really want to talk about some things that might suggest something other than a routine pneumonia. And then I'll spend a little bit of time, I'm not sure exactly how much, it depends when we get there, about rationale for radiographic follow-up after a documented community-acquired pneumonia. So this is a patient with a fairly routine community-acquired pneumonia. We see a homogeneous opacity in the right lower lobe, see a more focal opacity in the anterior segment of the left upper lobe, nice ear bronchogram signs on CT scan. Very typical appearance for a community-acquired pneumonia. This actually turned out to be a Legionella pneumonia. Now, what is the information our clinicians want from or desire from us on the radiograph? And I'm going to point out two things. There's something called the Pneumonia Severity Index, which is used by clinicians to determine whether or not the patient needs to be hospitalized, whether they're going to need ICU care, and in some instances, selection of antibiotics. And this is a very complicated algorithm. I'm not going to go through it in any detail. I'll just point out one little thing in the fine print at the bottom. The only radiologic finding that actually comes into play here is the presence or absence of pleural fluid. So keep that in the back of your mind. The presence or absence of pleural effusion is important from our clinician's perspective for risk stratification. Now, there's another criteria which is used. This is promulgated by the Infectious Disease Society of America, endorsed by the American Thoracic Society, also used for similar purposes. This is a much simpler algorithm, as you can see here. Most of it's clinical. The only thing from a radiologic perspective are multilobar opacities. So the presence of multilobar disease is an important risk stratifier in patients with known or suspected community-acquired pneumonia. So it really does raise the larger question, what is it that the clinicians really want from us on a radiograph in someone they suspect of having community-acquired pneumonia? Well, first and foremost is to confirm, is there an opacity present which is consistent with community-acquired pneumonia? They are interested in some of these factors, multilobar disease, pleural disease, which are useful for risk assessment, severity, etc. Identify complications such as pleural fluid, which might suggest a complicated perineumonic effusion or empyema, presence of abscess, to serve as a baseline for follow-up in some instances, and also to suggest the potential for an alternate diagnosis. And that's what I'm really going to focus on in most of this talk. What are some things that would suggest an alternate diagnosis? So this was a young patient, I think they were 21 with cough and fever, and you can see that they have these patchy opacities in the right lung. So that looks pretty typical. There's a opacity here in the right middle lobe. So certainly findings are consistent with community-acquired pneumonia. There are a couple subtle findings here though, all right, for the eagle-eyed chest radiographic interpreter. There's some mass effect along the medial wall of the right main bronchus and the bronchus intermedius here. And there's increased soft tissue opacity back here in the region of the posterior wall of the bronchus intermedius. These findings suggest mediastinal and right hilar lymphadenopathy. And on a CT scan, of course, this patient got a PECT because that's the only cause for cough and fever, right? So they got the routine PECT, and you can see that they have fairly extensive subcarinal and right hilar lymphadenopathy. Well, this is a little bit of a red flag that this might be something other than a routine community-acquired pneumonia because adenopathy is really relatively uncommon, particularly adenopathy that you can identify on a radiograph. Now, you can see pretty large lymph nodes in patients with lung abscesses, but at least it should make you think about something else like tuberculosis, fungal pneumonia, or even non-infectious causes for the opacities such as sarcoid or neoplasm. After sort of a prolonged evaluation in this particular individual, this patient was found to have acute histoplasmosis. Another patient presented to the ER with cough and fever one night, and you can see that they have a heterogeneous opacity in the right upper lobe. There's some air bronchogram signs here, but there's some areas of rounded lucency suggestive of cavitation, and there are nodular opacities in dependent portions of lung, both on the right and perhaps a little bit less apparent on the left. Now, this could be a community-acquired pneumonia. You can certainly see cavitation, for instance, in MRSA, Legionella. Occasionally, even pneumococcal pneumonia will cavitate. But the location and the appearance here should suggest the possibility of another diagnosis. So things like cavitation, all right, I'm not going to say that they don't occur in routine community-acquired pneumonias, but they should at least make you think of alternate diagnoses. Abscesses, of course, MRSA, and as I mentioned, sometimes Legionella, particularly in immunocompromised individuals, but also things like tuberculosis, non-tuberculous mycobacterial infection, fungal pneumonias, and non-infectious things like neoplasms or vasculitis. This was a CT performed in this patient. You can see the cavitary consolidation in the right upper lobe, but notice the small, uniformly sized 2 to 3 millimeter nodules in the contralateral lung, more cavities. All right, and in the inferior portions of the right lung, some really beautiful tree and bud opacities here. So we have tree and bud on the right. We have smaller regular nodules on the left, which are more randomly distributed. And so these findings are really suggestive of active pulmonary tuberculosis. Now, does it have to be TB? No, it could be non-tuberculous mycobacterial infection. In fact, in our population, that's probably more common. But TB is the one to think about, of course, because of the public health implications. So this is an old article. I don't know if anybody remembers Dr. Woodring. He wrote a series of really beautiful articles back in the 80s and 90s from the University of Kentucky. And they looked at a series of patients with tuberculosis that were either had delayed or completely misdiagnosis. And they identified a couple features or findings or causes for misdiagnosis. Failure to recognize lymphadenopathy as a clue to an alternate diagnosis like TB. Anterior segment disease. I mean, we always learn that you don't see TB in the anterior segment. That's not true. Anterior segment disease occurs not uncommonly, but often in the setting of more widespread disease. But it doesn't exclude TB if the imaging findings are suggestive. Overlooking minimal lesions on radiographs or CTs, mass-like lesions with satellite nodules, but most importantly, just the failure to think about TB in an appropriate clinical setting. So just think TB in some of these circumstances. This was a young individual with fever and chest pain presented to the ER, and there are these little thin-walled nodule cavities as well as more solid nodules, fairly sizable in the mid and lower lungs. Now, because of the clinical presentation, the patient was treated with a broad-spectrum antibiotic, and they came back 2 weeks later. They are clearly worse, more nodules, there's pleural fluid now, the heart is larger. Notice how peripheral the nodules are. Patient now had a heart murmur. Echo showed a tricuspid valve vegetation. The patient was an IV drug abuser. And this is intravenous or septic emboli in the setting of IV drug abuse. And this is a very characteristic appearance for septic emboli on the CT. Peripheral thin wall cavities, air fluid levels, some more solid nodules. A larger, more irregular area here, that may be a frank abscess, and pleural fluid. So community-acquired pneumonia doesn't usually manifest with large nodules, okay? You see that, you start thinking about, well, maybe this is some sort of hematogenous infection. If they've got a line in, maybe it's a line infection. Tuberculosis, non-tuberculous mycobacterial disease, fungal disease, and then non-infectious causes such as neoplasm or vasculitides. This patient was having chest pain and dyspnea. They obviously have a defibrillator in, so they have underlying heart disease. I think their ejection fraction was like 15 to 20%. They have a very homogeneous opacity here in the right mid-lung, which is centered in the right middle lobe, as you can see there. What would be your diagnosis based on the CT appearance here? Just anybody shout it out. So on the CT, it's a very well-defined lesion with a rim here, with this internal bubbly lucency, somewhat ground glass. It's a bit wedge-shaped. It's a vessel leading to it. It's a very typical appearance for a pulmonary infarct, and there is an associated right pleural effusion. So this is a pulmonary infarct in a patient, and here's the follow-up contrast-enhanced CT with the clot in the right middle lobe artery. So pulmonary infarct in this setting. So what were some of the clues here? Well, one of the clues is there was some discordance between what we saw on the radiograph and how the patient was clinically manifesting. A patient with a rip-roaring community-acquired pneumonia like that, you'd expect to have fevers, cough, be quite a bit sicker. This patient had the chest pain, et cetera, but they were otherwise relatively clinically well appearing for them, at least. And then, of course, the appearance of the lesion in this case, on the CT scan. So pulmonary infarcts on CT or radiographs, of course. On radiographs, we tend to see them as peripheral, opacities that are somewhat wedge-shaped, rounded, lower lobe distribution, the classic Hampton hump. On CT scan, they tend to manifest with peripheral opacities that often have these bubbly internal lucencies or ground glass. The margins are often well-defined, particularly as the infarct matures. Early on, it may simply be more of an amorphous area of opacity, sometimes just ground glass. But as it matures, it gets more well-defined. That's called the melting sign. You typically do not see air bronchogram signs in pulmonary infarcts. You should be aware that you're more likely to see infarcts in patients with PE when they have concomitant left heart disease. Remember, the lung has a dual circulation, so if the bronchial circulation is compromised as well, patient is more likely to develop an infarct. And pleural fluid is seen in over a third of cases, I think. Now, one of my colleagues has termed this the blood orange sign, and that's because these things look cut on sides sort of like orange slices. But because histologically they're actually areas of hemorrhage, Travis thought that this would be better termed the blood orange sign, but it's a very typical appearance on CT scan for infarcts. Leads me into a little discussion. What is the role of chest CT in a known or suspected community-acquired pneumonia? Well, we all know it will have increased sensitivity. That makes sense. But in one actually pretty good multi-center trial, it was done in 4 ERs in France, it also had better specificity than the chest radiograph. And they found that in their setting, when they compared to CT, the chest radiograph was falsely negative in a third of cases and falsely positive for community-acquired pneumonia in a third of cases. Interesting stuff to think about. CT is, of course, helpful for useful for confirming an alternate diagnosis, evaluating for central obstructions if suspected, presence of lymphadenopathy, and to identify complications such as pleural fluid or abscess. Next case, this was an elderly woman with dyspnea. This is her first radiograph. We see these peripherally oriented opacities. You see there. At this point, she was given a Z-Pak and sent home. She comes back quite a bit sicker about 5 days later, and you can see she's got progressive peripheral upper lobe opacities at this point. This elicited a bronchoscopy. A bronchoscopy showed as suspected loads of eosinophils from the lung, and this is an eosinophilic pneumonia. It turned out that the patient, I'll come back to that in just a second. So clues here to an alternate diagnosis is the symmetry. If you think about it, most community-acquired pneumonias that we've all seen tend to be asymmetric processes. They're usually sublobar, right? But when they're multilobar, there's almost always one lobe that's affected much more severely than the other. When you see opacities that are relatively symmetric, that should be a clue, well, hey, maybe this is something a little bit more unusual. And symmetry itself favors non-infectious etiologies such as pulmonary edema, inhalational disorders, acute eosinophilic pneumonia, for example, organizing pneumonia, and the like. So remember symmetry as something that might clue you into an alternate diagnosis. And as I mentioned, this turned out to be an eosinophilic pneumonia. It turned out that one of these shoulder prostheses was infected and the patient had been started on daptomycin. Daptomycin is one of the drugs with a side effect profile that includes eosinophilic pneumonia. In fact, I've probably seen more eosinophilic pneumonias related to daptomycin than any other drug. Eosinophilic pneumonias can occur idiopathically, but most of the cases I've seen recently turn out to be related to drugs that are administered, things like daptomycin, non-steroidals. There's a whole host of drugs. If you live in a third world country, parasites that transit through the lung can cause that. And then rarely it will be a manifestation of vasculitis, so-called eosinophilic granulomatosis with polyangiitis, what was used to be called Churg-Strauss syndrome. Okay. And this is really a characteristic appearance for eosinophilic pneumonia. This is sort of the reverse batwing or reverse pulmonary edema. Here's a patient with batwing edema. For contrast, this is the exact reverse or photographic negative, if you will, of pulmonary edema. All right, so last case is a patient with a productive cough. They presented, they really didn't have much in the way of fever, but a very productive cough. And they have this sort of nondescript opacity in the left lung. Certainly looks like a community-acquired pneumonia to me. The patient was treated. They were followed up in about 2 months, and you can see that the opacity has gotten significantly worse in that period of time. Now, I think most of us at this point would suggest the CT to better characterize this opacity to make sure we're not missing a central obstructing lesion. For whatever reason, at this point, the clinicians decide, well, we're going to give you another couple months of antibiotic therapy and bring you back. And there they were at 2 months, and here they are at 4 months, and you can see we've got progressive consolidation in the left lung, and now we can begin to discern some opacities in the contralateral right lung. At this point, a CT scan was performed. I'll come back to that in 1 second. So the clue here that suggests an alternate diagnosis is non-resolution, right? Okay, I'm going to talk about resolution here in just a second. But non-resolving pneumonias, we think about unusual organisms like TB or fungus or non-tuberculosis, et cetera. Non-infectious inflammatory conditions, vasculitides, et cetera. And then neoplasm. So let's come back to the CT scan here. And as I scroll through the CT, you can see the locus in the left lower lobe, which was the initial site of involvement on the radiograph. A homogeneous opacity, but elsewhere within the lung, you can discern these little centralobular ground glass nodules and then more confluent opacities in the right upper lobe. And then going into the lower lobes, we see much more extensive opacities. There are a couple areas where you can see a little bit of superimposed septal thickening, so there's a little bit of a crazy paving pattern here. And then down into the lower lobes. What's the diagnosis here? Yeah, I think I heard it out there. This is going to be a mucinous adenocarcinoma. The time frame, 4 to 6 months, the progression, et cetera, all fits. The radiographic features are really fairly typical of that, and so this is a mucinous adenocarcinoma, which at this point involves both lungs. Frankly, if we had done a CT at time 0, I would suspect that we would have seen contralateral disease on the CT scan as well. So this raises the question of follow-up, and this is actually one that's difficult to answer scientifically because the data really is very limited. Questions that we might ask is, do we always follow up a pneumonia or what we think is a pneumonia? Do we sometimes never? There are those that never recommend follow-up. If it's sometimes when, which patients do you recommend follow-up on? And if you do recommend follow-up, how soon, how often? All right, and that is often a point of variability. This is probably the best single study. This is a retrospective study of almost 3,400 patients, of which 40% had chest radiographic follow-ups within 90 days of the diagnosis of pneumonia. And in those 90 days, about 1% of those patients were ultimately diagnosed as having lung cancer. So it's fairly low incidence there of lung cancer in patients with suspected community-acquired pneumonia. But remember, we only got follow-up on about a third of the cases. The overall chest X-ray diagnostic yield was about 2.5%. That includes alternative diagnoses. As you would suspect, age greater than 50, male sex, and the presence of or smoking were predictors for a diagnosis of cancer in patients with initial presentation of pneumonia. And this just shows you the stratification. If we just look at the bar for diagnosis of cancer within 90 days, which is here, you can see that in the under 50 age group, it was infinitesimally small, and it increased once you got up to age 60. This led the associate editor of the Archives of Internal Medicine to opine that routine post-treatment chest radiographs were not indicated in patients with low risk for lung cancer and whose symptoms resolve with treatment. Okay. Now, Brent Little at Mass General published this study a couple years later. This was also a retrospective look of 805 patients. A larger percentage had follow-up between with a median follow-up period of 80 days. And in those 80 days, in these 618 patients, they came up with 5% with an alternate diagnosis, a fairly low incidence of lung cancer again, 1.5%. But they picked up a lot of other things like pulmonary infarcts, eosinophilic organizing pneumonia, and they concluded that follow-up was useful in their particular population, mostly because you picked up some of these alternate diagnoses. So what are the guidelines out there? Well, the Infectious Disease Society and the ATS opined in 2019, which to my knowledge is the most recent guideline, that if the patient was clinically improved or their clinical symptoms have completely resolved, that the clinicians did not need to order a follow-up radiograph. But they opined that this was conditional recommendation based on poor data. But frankly, the problem is, of course, we don't have any prospective randomized data to try to answer the question more definitively. The British Thoracic Society, in an update on their online recommendations in 2015, suggested a follow-up in 6 weeks if the patient had persistent symptoms or were at risk for lung cancer. Of course, those are things that we don't know, right? When you're thinking about how do you dictate the case when you see the first film, right? You don't really know necessarily what the risk factors are. You don't know if the patient's symptoms are going to resolve and that sort of thing. And that makes it difficult for us, I think, in knowing what to do on that initial radiograph. So Dr. Humphrey surveyed members of the Society of Thoracic Radiology in 2013. At that time, there were 735 members. We're now over 1,000. But only about a third responded, and about half of those said, well, they always recommended follow-up, and then a little bit more than half recommended that sometimes, depending upon things like age, clinical history, smoking history, known malignancy, radiographic features, immune status, but radiographic features tended to be the one that was most commonly used to suggest a follow-up. So they looked at it, they said, this doesn't exactly look like a routine community-acquired pneumonia, let's get a follow-up. All right. So if you're going to follow up, what's the timing? Well, the timing that we typically use is based on two very small studies. The first one was in 288 patients who were hospitalized. So these patients had severe community-acquired pneumonia, and they were getting radiographs quite frequently. And they found that as long as the patient was clinically improving, it really wasn't useful to get a film less than 28 days from the initial film. That was if they were clinically improving. There was a very small study in '94 of 81 immunocompetent patients where they followed them at 2 weeks and at 4 weeks. And at 2 weeks, 50% of the radiographs had normalized, and at 4 weeks, 67%. From that, they extrapolated that at 6 weeks, 95% should have normalized. And that's where we get that 4 to 6 week from this very limited data here. Okay. So if I summarize the data on follow-up, I'd say it's limited, it's equivocal. It's probably true that a less than 6 week follow-up is not going to be useful unless the patient is not clinically improving, or of course if they're clinically worsening. I tend to recommend a follow-up at 6 to 10 weeks, particularly if I know that the patient's at increased risk for lung cancer, if they're an older individual, say in the range of 50 years old, if there's some discordance between what I'm hearing clinically and what I'm seeing radiologically, et cetera, and if there's something about the appearance, if there's some atelectasis that might suggest a central obstruction, lymphadenopathy, and those sorts of things. But there is a tremendous amount of variance even in the practice among our group. I think we have 12 or 13 thoracic radiologists, and I don't think we have a completely uniform approach. But I just wanted to give you some of the data as limited as it was. Okay, so clues to alternate diagnosis: lymphadenopathy, appearance, cavitation, large nodules, discordance between the clinical and the radiologic manifestations, symmetry of opacities, and of course non-resolution. So coming back to this is a patient with chest pain and low-grade fever. In this case, we have a peripheral opacity. It is very well defined. We have those central bubbly lucencies. We have a pleural effusion. Well, that's not particularly helpful. We'll see that in community-acquired pneumonia. But this appearance is really suggestive of a pulmonary infarct, and I think that was the most common diagnosis as well. And certainly when you see this was a non-contrast CT. You know, the patient had a radiographic opacity, they got a CT. You see this appearance, you want to think about the possibility that it could be due to an infarct. We did a contrast study. We see a lot of this clot is actually fairly peripheral. I think a fair amount of it is actually chronic. I think it was probably acute on chronic PE here. So very large clot here in the distal right PA into the interlobar artery and into the middle lobe with the characteristic appearance of a pulmonary infarct. Okay. If you want to know more, my colleagues and I published this article a couple years ago now in the clinics. It basically goes over a lot of the material that I've covered in this talk, but of course in greater depth. Thank you very much for your attention.